All right, take it away, Bruno.
Wow. She's up there. Hi, folks. So I get to come here at least once a year to do this talk, so it's kind of fun. So we're going to talk about what happened at AAIC 2024. And luckily, this is actually scheduled from 10 to 12 because Stephanie learned that the first one of these I always go way over. So she made this one 2 hours instead of 1 because you guys are going to be guinea pigs. We're stuck again. Okay, so I have to do university disclosures. I don't have any. I get research support for a number of studies from NIH and the Alzheimer's Association, and that's about it. And my kids live next door to each other in Ann Arbor, so I have no money. All goes to their houses. However, they live right next door to each other, and they live right by the stadium, so it's in and out parking, so they make a fortune on Saturdays. It's amazing. So I always thank everybody first because you all donate to our center or to the Alzheimer's Association. You all pay your taxes, which funds part of my research. So all of those good things. So I try and start with a thank you there. This is what I hope we'll cover today. We'll do a little bit of background about the biology of the disease, and then we'll talk about advances in detection, diagnosis, treatment, all those different things that popped up at AAIC. And I can't cover everything that was at AAIC. And last night I got sidetracked instead of making slides, watching a couple talks I missed because they were really interesting. So there's just so much there. It's amazing. And I'll talk to you, if we have time, about a little bit about the MADers. And hopefully, like I say, it's news you can use, you can tell people about, and you can talk about. So first of all, this was in Philadelphia. I never made it to the bell because the stupid thing lasts this conference goes on for 5 days or whatever. I mean, you're at the conference all day long. And then me and my walking, I have never seen a walk between one speech to the next speech and then back again. You know, it seems like nothing I wanted was in the same place each time. But it's a gorgeous place. The conference center was the railroad station. So it's really neat, but it means it's very long. So it runs for quite a ways. So this just gives you a breakdown a little bit about this meeting. This is the largest and was the first single disorder meeting ever really started. It started, I think, in 2002 or 3 or 4, somewhere around there was the first one I went. I did not go to Stockholm. That was the first one. So I did miss the first one. I've been to all the rest. But 14,400 attendees. This year and last year, the in-person were quite reasonably bigger than the virtual. And the in-person is about where it used to be. It used to be around 9,000 to 10,000. So you can see that it's really climbed back up again. And now virtually across the world, it's really increased the coverage. And there were 159 scientific sessions, 809 podium presentations, 5,400 abstracts. It was just incredible. As a matter of fact, they had so many abstracts that basically the whole middle of the day was just spent wandering around looking at posters rather than hearing talks. So 3,500 posters. And it was really, really amazing. And this year, you'll see there were 882 virtual poster presentations. So really, there were quite a fewer virtual than there were in person. So that was pretty neat as well, and quite a change from COVID. So let's talk a little bit about Alzheimer's disease. So we're all kind of on the same kind of bend as we start to look at this research. First of all, Alzheimer's disease is a continuum from basically preclinical, which has no symptoms, but biological changes in the brain may be going on through very mild symptoms, through symptoms that may slightly interfere with daily life, and to symptoms that most definitely interfere with daily life. And when you get out here, out in this section, that's dementia. Because dementia is explained as cognitive changes that affect somebody's daily life, so they can't carry on their usual activities. That's a dementia. Alzheimer's is the largest percentage of the dementias, and as a matter of fact, it's really in the 70, probably to 80 range, because in truth, so many of these disorders are comorbid as we get older. So you'll find somebody with Parkinson's disease and Alzheimer's disease, or somebody with vascular dementia and Alzheimer's disease. But about 1 in 9 people age 65 and older have dementia, but you can see it goes up with age. So 5% 65 to 74, 13 75 to 84, and 33% of people age 85 and older. There are also in the US about 200,000 individuals with early onset, sort of in the very early 60s and 50s and 40s on down to 30 years of age. These individuals are an interesting group because they have sort of pure Alzheimer's. They're almost too young to have mixed in Parkinson's and other things. And so there's lots of research that goes on with these individuals, kind of looking at that. This is the kind of classic picture that gets updated every year with slightly different numbers up here of how many people to expect with Alzheimer's disease. But you can see we're around 7 million individuals, and then it goes up to 13.8 by 2060. And you can see the difference with age, because what's the biggest predictor of Alzheimer's? Age. Age is the biggest predictor, as we saw before on those numbers. So you can see in this group here of people 85 and up, you get a much higher percentage. And then this is the 75 to 85. But as our population ages, which it is doing, the number of individuals with Alzheimer's going up dramatically. Also, there is a sex difference here. Men are less affected by Alzheimer's than women. It's always hard because it seems to be harder to get a guy to come in for research. And so sometimes these numbers are a little bit jumbled because the number of men in general is lower. But if you look at the basic health statistics, it really appears women are more affected. And that is not because they live long. That's not the reason why, because that's adjusted. There also is a regional. But last year was the first year that they ever did a nationwide consensus of all the counties across the United States. And you can see that there's a little, see, we made it, we're kind of okay. But you can see also age factors and also diet factors and other things are involved, and size of the area to show you where the largest number of participants with Alzheimer's and dementia is. And it's interesting, you get this difference. This is important, and last year was really important for the first time doing this and updating it this year, because this suggests to you where dollars should go and where impact should go with healthcare. If you have certain areas clearly in need of more healthcare. Prevalence of Alzheimer's by ethnic groups is also very different. Non-Hispanic whites reflect about 10% of those with Alzheimer's. Latino Hispanics about 12.2%, and African American Blacks around 13.8%. So clearly there is a difference here by race, and that needs to be looked at carefully. And it's being looked at, and really in the last 5 years, 6 years, 7 years, it really hit its peak of interest as well. As has over the past few years, the fact that women have a higher prevalence, that's really become a big interest point as well. But this is the number of individuals you can see over time. Again, they both increase, and the Latino Hispanic group a little bit faster and more rapid as numbers increase. Another thing about it is it's really practically the only cause of death that increases. So if you look at, this is the percentage change in selected cases of death between 2000 and 2021, and there's Alzheimer's, and here's everybody else. So prostate cancer has gone up a little bit, breast cancer barely, heart disease, stroke, HIV has gone way down thanks to CART, combined antiretrovirals. And this is dramatic in Africa and Kenya, where we have some research. The average age of death used to be, I think it was 50 something, and now it's 63. And it's going up every year because antiretrovirals have increased the population. So these are the Alzheimer's facts and figures. Every year they put out a new facts and figures infographic. Well, I like that term. But one of the things in this one is the fact that, like I already mentioned, we have nearly 7 million people with Alzheimer's disease. 1 in 3 adults dies with Alzheimer's or another dementia. If you look, again, this is that change in heart disease we saw, but the lifetime risk at age 45 is 1 in 5 for women, 1 in 10 for men. Again, there's a significant effect of gender in this. And now there's been a lot more research that's been going on about distributions of tau in the brain and other things, and looking at why there is this difference. People used to think it was the other way around because guys kept, hitting their heads in football games and things. We demonstrated that was not true, but it kills more than breast cancer and prostate cancer together. The cost is massive, $360 billion by 2050. When it's up around 12.7 million people, it'll cost $1 trillion of pure costs. The other big issue to talk about is the stress on dementia caregivers. And I would say that probably in the AAIC, the Alzheimer's meetings, I went for years and never heard the word care partner or caregiver. Nobody ever talked about it. And really over the past 8 years or so, there's become a big interest in that because everybody realizes that's the key for a lot of this, as well as for individuals without care partners. All of these issues are really important, but there's such a difficulty for care partners and increased depression, increased medical problems because they're not taking care of themselves, as well as an increased cost. And you can see caregivers for 18 billion hours. It's just utterly amazing. And we don't spend enough time looking at that. And we don't have any way, I'll mention later, of reimbursing that. But that may change. And these are the Alzheimer's facts and figures for Michigan. We're kind of behind in some of the dates, and so these numbers really have gone up. But it still is just as significant as these features here. And one of the things on this infographic I like that doesn't show up on this one is the workforce issues. So the number of geriatricians in 2021 is 164. The increase needed is 183% by 2050 because of the aging population. I don't think we can get there, no matter how hard Wayne State University tries with its geriatrics. The number of home and health care in 2020, 71,000, increase is about a 25% needed. But again, the other issue here is also the impact on the healthcare system. How many individuals go into the ER because their care partner doesn't know where to take them or what to do, or it's not clear because the person can't explain what the problem is. So then it takes up ER time, it takes up bedtime at a high cost and a high rate, and that is another problem that is only now really being looked at. I'll mention this again. If some of you have seen me give this talk before, we were talking about that a minute ago. This is sort of the traditional picture of Alzheimer's disease. This is pretty simplistic, but it's basically what happens. You have these, every cell has these APP or precursor proteins because everybody needs proteins, and precursor proteins are really long. So these little chefs come along called secretase, and they cut up the APP very nicely, but somehow gamma secretase comes along and doesn't cut it properly. Cells can't absorb it, and all that amyloid starts to plaque together in terms of oligomers and plaques, and basically mucks up the works in the brain. As that starts to happen, you get inflammation, and then that seems to be associated with tangle formation, which is another of the characteristic signs of Alzheimer's disease. And that happens when tau, which is the building blocks of these axons in our millions of cells in our brain, tau starts to fall out of these axons. The axons fall apart. The tau clumps, like the amyloid, but the tau clumps go back up into the cells or can affect other cells, and that eventually all causes cell death. So you get a loss of cells and a loss of cells to produce the neurochemicals that create the electrical relationships across the brain, and that's what happens. The other thing that happens is right now, this is where we diagnose people, down here. This process takes anywhere from 20 to probably 30 years, but we're coming into it down here pretty much until the last 2 years. But the other thing is, this is a Clifford-Jack model. Clifford changes the model every year slightly, but the idea is that if you look at abnormalities in the brain, certain biomarkers, these are measures of brain activity and measures of brain metabolism. If you look at these different changes that occur in the brain, some of them reflect amyloid, some of them reflect tau. You can see that there is first of all, a difference in the threshold of detection, but also the amyloid markers from either spinal fluid or PET scans, positron emission tomography scans, we'll look at in a minute. This goes much earlier than, say, cognitive changes or fluorodeoxyglucose metabolism in the general metabolism in the brain, or tau. So that if somebody first comes in with potential problems here, this is where tau is. This is what's happening in the brain as the cells are beginning to dismantle, but that's where their amyloid is, up there. So the question is, has the amyloid already done its damage far before somebody ever has a memory problem? Let's talk about early detection and diagnosis. So again, just to remind you guys, this is how we diagnose now. We do physical exams. We do imaging biomarkers or CSF fluid analysis, looking for amyloid or tau in the either less amyloid or more tau in the fluid. The neurological exam is done, and usually cognitive testing is done. So this is how we normally diagnose now. The problem with this is that so I'm going to do some comparisons to 20 years ago, because a fellow I know did that, was really good. They were comparing 2004 to 2024. In 2004, the average diagnosis was off by 40%. So people were being diagnosed wrong in about 40% of the cases. They were headed towards 50. So this was a real problem. One of the exciting things was PET scans. Amyloid PET scans were first being developed by Bill Kugel, and there's a couple of U of M people in there somewhere too. But you can see here the amyloid that accumulates in the brain even so early lights up on an amyloid scan, whereas in a healthy control you see very little. So this was seen as really exciting. And I can remember talking about how exciting it was. But it was available in maybe 5 or 6 centers around the country, and it cost $12,000 to do it. Now the price has come down to 5 or 6, I think. What is it, Anna? Do you know, for a PET scan? I think it's around. I think if you get an amyloid and tau, they give you a break, and it's only 8,000.
Yeah, I think it's like 7 something.
Yeah. So I mean, it's come down, but not really. But that's the state of diagnosis. Now there are many more PET scanners out there, and even little mini PET scanners people are trying to develop. But in truth, in 2004, all we could talk about was this, because we weren't talking. That was the other problem, is we weren't talking about all these other things like race differences, gender differences, peer partner problems, because we were locked into just trying to diagnose this disease as early as possible. So we do it. This is what's our diagnosis. Symptoms. If you're lucky enough to be in a center, you got one of these scans, and then when you pass away, we looked at your brain to see if you had the sort of characteristic plaques and tangles. These little long tangles here and all these plaques. So what's changed in 2024, which is really quite exciting, were the IDEA studies from Rabinowitz and Company, Gil Rabinowitz and Company, that really have looked at a lot of patients with just amyloid scans, just PET scans, and found that if you provided these to physicians, there was a 35% change in the diagnosis they initially made, and the management changed 60%. This was, and the EMIPAT study showed a 3.5% improvement in early diagnosis of Alzheimer's based on that. This was all done so these guys down here would finally agree to pay for PET scans and to pay for them more generally, which they have. Originally, it was like, okay, we'll pay for a PET scan, but only if it's a question of frontotemporal dementia versus amnestic, and we won't pay for it any other reason. Now it's gotten much broader coverage. And another thing they did, and this is from this study, from IDEAS, as well as in ADNI, which is the Alzheimer's disease neuroimaging study, which is a very large neuroimaging study. They really both have gone about trying to increase the number of underrepresented and underserved individuals in their studies. And in about a year, they've increased these studies dramatically. But if you look at the number of people here, the percentage of people who had the scans, and if you look at change of management, it's pretty much the same across the board. So you can say that providing an amyloid scan really does make a difference. Got to find the money for it. And now, as of this year, there's an FDA-approved tau scan as well for clinical purposes. So this is really pretty darn exciting. And this is was a study presented at AAIC where they went about and took 11,000 individuals from a set of different cohorts looking at tau scans, and showed that you can clearly see that amyloid increases with age, and that it increases faster in women than men. It increases faster in women, but it doesn't have the same kind of classic distribution that it does in men. So it's there's intriguing differences, but it's coming. This, of course, is how fluid biomarkers in the past have been approved. If any of you have heard about fluid biomarkers and the importance of that, of looking at A beta for amyloid plaques and tau, we used to do it this way all the time, and still, but that's not taking a spinal tap is not exactly the biggest thing of interest, although people don't realize how tiny that needle is, but it's not an interest sake. So this is, another individual described this as the belle of the ball. So this was all anybody talked about at AAIC, was the use of blood-based biomarkers instead of those big giant PET scans and those scary CSF studies. Because if you could do this, it would be amazing. If you could go into your doctor's office and get your cholesterol checked as well as getting your amyloid and tau levels checked, it would be pretty darn amazing. And this stuff has increased dramatically over the last 3 years. Just the number of talks, the number of companies, the number of small companies that popped up out of nowhere to do, it's sort of like the Wild West out there. But that's one of the issues with this is everybody's got a company and everybody's doing it, but still it's critically important. And now we know a lot more about what these different markers do in terms of, do they label plaques? Do they label plaques and tangles? Or do they really look at co-pathology and changes in the brain? We know a lot more about this than we did last year. It's incredible how fast things are moving. And so there were 3 interesting studies that everybody was sort of talking about. Maybe we're talking about all of them, but 3 of them in particular, because it relates directly to clinical work. There were, in one blood test, in one study, they found that it was 90% accurate in identifying Alzheimer's disease in patients who came in with cognitive symptoms seen in primary care. So they basically did the same thing that IDEAS did with amyloid scans, but they did it with blood and said, look how much better we are. Primary care physicians are 63% accurate. Specialists, not our specialists, but some specialists, 73%, 90%. So, but blood test itself was 90% accurate. And so blood tests, once they're confirmed, could change recruitment to clinical trials, could slash wait times, could make, us looking at amyloid and tau across race divides and across gender divides and everything, because it makes it much easier. I have 3 studies going on now in Africa, all of which use blood-based biomarkers, because I'm not going to find a PET scanner. And the scientific head of, when they were first talking about changes in diagnoses and using PET data and amyloid data to try to show, to try to use for diagnostic purposes, promised PET scanners in every country, and I never saw one in any of the countries I work in, but that's true. But that's because now we have these blood tests. They're not perfect yet, but they're really coming along fast, incredibly fast. In another study, they looked at 2,718 people from a bunch of studies, and that one suggested that p-tau217 alone was sufficient enough to select cognitively unimpaired people who had amyloid in their brain who might be very good for a clinical trial. And that clinical trial has already enrolled everybody. So this is a really interesting feature. Another study looked at the sort of forecasting models to show if you used blood-based biomarkers, you could really reduce the wait time for an Alzheimer's diagnosis and move people through the system much faster, get them into clinical trials, get them into care work and all those other things needed at a much faster rate. So blood-based biomarkers, really exciting. And everywhere, There was the one company from China that did test using the COVID, our little COVID scanner, except it was a dementia test. And so you just had to spit in it and then it would tell you, but I didn't. They were being absolutely cynical. So I took the sample home and my wife got a little bit upset because she said, "Is this directed at me?" And I said, "No, I forgot I had it in my suitcase. I didn't need to have it in there. It just happened to be there." So the whole point is, what do we gain by these blood-based biomarkers? We get wider, more equitable access to really clear amyloid targeting therapies and research studies and to diagnosis. We can facilitate trials tremendously, and especially if you can do preclinical disease. Now, those some may argue whether that's good enough to include in a study, or you need to do a blood-based marker and a PET scan, but that's still a matter of discussion. But all of this stuff comes with the fact of, do you just start doing these willy-nilly when you come into the doctor's office? Do we understand what that means? I mean, suppose you take two different people, somebody comes into the doctor's office with a little bit of mild memory loss and a little bit of confusion and keeps losing keys, and somebody else comes in who has absolutely no problems, but their mother had Alzheimer's. Do you do this testing with both of these individuals? What would be good ideas? How can we be consistent from one primary care physician to another? Because you could easily see how these things could be misrepresented, because 90% effective is still not 100% effective. And if you do these on somebody with a low probability and it by chance turns out high, you could really damage somebody's life there. So one of the other interesting things that came out of this meeting was there's going to be a practice guideline development through the Alzheimer's Center to look at blood-based biomarkers. And they're going to do this big literature review, sort of like if anybody's heard of the Lancet reviews, it's very similar to that. They use this framework called GRADE to evaluate every paper and everybody's opinion of every paper. And then it moves through, and then they'll get a systematic review that hopefully will lead to clinical practice guidelines, maybe even to tools favored before others, as well as education. And this is the whole group of people in this committee who are going to do, or have already started doing a whole heck of a lot of work, and promise that by mid-2025, you promise, they'd have their results out, which I find hard to imagine, because I think in the space of 4 or 5 days at the AAIC, there were probably 20 or 30 papers published on blood-based biomarkers. And these are the questions they're going to ask. So they have, I think it's like 6 or 7 or 8 sets of questions, but these are the first 2 questions they're going to ask. And it makes sense. Can a blood-based biomarker, can that be used as confirmation for Alzheimer's disease in a diagnostic workup when you have somebody with cognitive impairment? Can blood-based biomarker be used as a triage? And the same thing down here when somebody does not have cognitive impairment. How good are these blood-based biomarkers? That's what this group is going to do. And this group is going to say, hey, guess what? This is what we recommend. Very similar to when aducanumab and lecanemab and the donanemab have all come out, the new medications, brand new medications for Alzheimer's come out often with guidelines that have been worked out with guideline groups on what's the appropriate way to do things. I think that's important. There's another reason why this is important. This was a cute study that I thought was a cute study done on a large group of people. And it also shows you now we've gone beyond my day of studying 25 people and being all ecstatic that I tested 25 people and stuck them in a PET scanner or whatever. You know, now with multiple large studies across the country, you can start to utilize that data. But there's a question that this fellow had about, you know, we know there's so many different symptoms associated with Alzheimer's, and this has been done by others, but he did it particularly elegantly from a statistical standpoint. What if we took all these different symptoms and looked in a large population of people to see whether Alzheimer's disease is really the same? I mean, we always say you have to have it used to be you had to have memory plus one cognitive area impaired, and it had to affect your everyday life. Then you could be diagnosed with Alzheimer's. Now it's 2 cognitive impairments, because we realize that there's a reasonable number of people who come into clinic who don't have a memory complaint to start. So we're trying to understand this better. So he used a number of different data sets. They had 2,000 people who had basically the same or harmonized the way they do it, put all this data together, and they found that they felt they could find 5 very clear types of patients with Alzheimer's. Some who had primary memory, some who had language and hyperactivity, some with visual motor and mood, some with sort of just global problems but no behavior, and some with global problems and behavior. And why does this make a difference? Well, first of all, the interesting thing is their amyloid scans may not have shown differences, but their tau scans did, and those areas were related directly to the primary. So you get memory areas affected, you get language areas affected, and mood, and all these things match the tau areas that were affected by tau abnormalities and the amount of that tau abnormality. And the other point is they found that these individuals changed at a different rate over time. So you could look across 5 years and see it kind of makes sense. The people with the sort of very pervasive symptoms, global with behavior, changed much faster than those who were primary amnestic. That was their predominant problem. So that typifying people by their symptoms, whether they're behavioral or cognitive or what, is also important when we look at what we can tell patients. And as a matter of fact, this group in Pennsylvania is now, they have a home-based test kit where somebody can do cognitive and behavioral things, and it bounces you back with an estimate for what type of person, what type of pattern, which of those 5 patterns you fall into, which I'm not quite always so sure about widespread distribution yet, but we'll see. So then every year, Clifford Jack, the fellow with the picture I showed you before, gets up and causes a stir, because Clifford likes to cause stirs, even though he says he doesn't cause stirs. But every year he comes back from the work group, from the diagnostic work group, with some subtle changes or not so subtle changes in diagnostic, in the diagnosis of Alzheimer's disease. Don't forget, this disease didn't have a diagnostic pattern till whatever it was, 1982, whatever it was, even though it was first described in 1901, you went like 80 years or 70 years, 75 years before anybody ever said, okay, this is what this disorder looks like diagnostically. So it's important, because if you have a diagnostic pattern, then you can treat, and then you can understand differences among people. So Clifford also, they got a lot of flack last year's AAIC that I don't think they were ready for, about the fact that basically it looked like they were going to define Alzheimer's disease exclusively from blood-based biomarkers. So if you've got amyloid, we're going to call you AD whether you like it or not, and we're going to treat you like you have AD, which caused a lot of concern about insurance, caused a lot of concern about there's good 20% of people in this world wandering around with a brain full of amyloid and tau, and yet they have no cognitive symptoms at all. So we haven't understood those things yet, but said, this is going to provide us some general principles to stage this disease It's not specific practice guidelines. We're not going to get involved in practice. But we're going to try and show you a way that we could maybe look at this and kind of bridge clinical practice and research practice. It's a little bit confusing, but we'll go over it quickly. So for one thing, they divided things into biomarkers and core. So core 1 was amyloid biomarkers. Core 2 was tau biomarkers and tau PET. Then we had measures of non-specific things that are involved in Alzheimer's disease, like cell systems degenerating, as well as biomarkers for non-AD but associated disorders. So each year it gets more specific and more complex, but it's to the point of showing that this group of core biomarkers changes very early, the amyloid biomarkers, and the other ones change more slowly. So these become your risk markers. Amyloid markers become your risk markers, as well as p-tau 217 that has an overlap there. But these become your risk markers, whereas tau and fluorodeoxyglucose and things and MRI become your markers of clinical care. So these might be things you might enter somebody into a clinical trial with, and these might be the markers that tell you whether you're successful in changing the disease or not. So the markers could be used different ways, and that's really important. So there was a lot more things in this because it bounced back and forth, but basically the argument is core 1 biomarkers can be used for early detection of people without symptoms. Now it became early detection, but confirmation that Alzheimer's disease is and if somebody has symptoms, it becomes confirmation. Some slight word changes from last year, but it makes people in general a little bit happier. So it's not, you have abnormal amyloid, you've got the disease. Clifford thinks that, but you know, not going to say it out loud. And then the clinical staging, this clinical staging is exactly what it was. This is staging with biomarkers of Alzheimer's disease along a continuum. This is what it was last year when it came out. And you'll notice that there's a stage 0 here, which is no evidence of clinical change, but biomarkers are still in the normal range. This is for individuals with Down syndrome or with presenilin genetic markers, where we know that individual has an exceedingly strong risk of Alzheimer's disease. And now if you give it a stage, you can treat, and you can treat ahead of time. So that's what's happening in a number of different studies. So that's important. Stage 3, cognitive impairment with early functional changes, everyday changes. This is what MCI really is, and then you move into dementia. They also developed ways to grade how badly your amyloid and your tau PET scans look, to try to say, okay, we're going to try to say that we have biological ways of differentiating staging, like amyloid PET scan is early on before tau appears, so that it's just a risk. Then tau, very specific areas, tau a little bit wider, and tau very wide in the brain. So there's this nice area that was done, and I missed the slide. But there was a slide going to show you that they then tried to mix together clinical and PET imaging to try to say to people, we know that these things should move together, but look at all the variability. And that variability becomes something important that we can study. So let's talk about some advances in treatment. So this is where we have been with treatment, with some exciting things at the bottom. But from the first description of Alzheimer's disease in 1906 by Dr. Alzheimer's, it took till 96 for the first Aricept that really was used then. When I was in New York, we had an early version of Aricept you had to take every 40 minutes. So it was not exactly an effective medication, but at least it allowed us to start to look at that, and then it became time release. But really, until you got into the ribostigmine, the galantamine, the memantine, these medications here are all in orange because they help with treating symptoms, cognitive function. They improve the amount of, remember I said before, when cells die, all those type of brain fluids, acetylcholine, all those things that allow us to make electrical connections in the brain start to disappear. These help by flooding those systems. So these keep things going a little while longer, but they don't do anything against the actual disease. And now we also have two new drugs that have come out fairly recently. One affects sleep behavior disorders, and one has been approved, Rexulti, for actual Alzheimer's. You might have seen the ads on TV for it even, but it affects behavior in Alzheimer's disease, and we never really had an approval that was effective. So these are really interesting, but all the news is in these babies, aducanumab and lecanemab and donanemab. These drugs are the drugs that actually are in dark because they slow disease progression. They affect the disease. They affect the disease by getting rid of amyloid. So that's a big deal. And of course, there's a lot of interest in how that works and when it happens, and we'll talk a little bit about that. But these are really the game changers, and these all got approved in the last year, 2023, 2024. So aducanumab was approved in 2021, but we don't talk about it too much because it didn't. The whole process didn't quite work so well. But there was a sister drug coming along the way. So these drugs, 23 and 24, lecanemab and donanemab, really are game-changing drugs. They're not perfect. They postpone things. They don't make things better. It would certainly be nice if we could sort of flatten the disease or improve the disease, but these actually change the progression of the disease, so they are changing the disease. And once, Harry Johns, who used to be the head of the Alzheimer's Association, used to pray at night just to have one drug approved, because once you get one drug approved, you're going to get a lot more approved. And once you break the ceiling sort of thing, then a lot of other people can come along with drugs because they'll see that it's possible to get drugs into market, and they'll put money back into this. So it's very exciting. I just wanted to mention this again because this is Rexulti is a major improvement for people, but it comes with, as they say, a black box warning that says there may be some problems if people have psychosis. So you've always got to be careful. So this is where this whole thing started. Back in I think it was 2003, 2004. No, it was before that. I can't remember the date now. If anybody can remember the date, just yell it out. But was the first study in mouse models to show that a mouse full of amyloid, you could get rid of it by giving them a vaccine. That was really super exciting. Everybody, and there was a giant Science magazine cover. There was a giant Nature cover. In my other talks, I got lots of pictures of those covers because it's all very exciting. And unfortunately, this individual has passed away to see the changes now. But what happened is they then moved this into human trials, and the trials were immediately stopped because of side effects. And a small group of the people developed meningitis, but in the studies they did of those that did not develop meningitis, and even those that improved after having meningitis, there really did seem to be a signal there. And it got, there was this whole idea that maybe we can do immunotherapy. Maybe we can label these things and let the body get rid of them. Maybe there's a way to do this the way we vaccinate people for other things. And that was 2004. This is 2024. 20 years later, we've got two drugs approved. One is licensed in a lot of places and one so far in the US. So this is really exciting stuff. We also know a lot more about these anticlonal antibodies. This is amyloid is a key protein that accumulates in the brain. As I've said, you can remove the plaques and see a slowing of the disease progression. You don't see improvement or stoppage, but you do see a slowing of progression. Antibodies are produced externally and based on a manufacturing process, and then the person gets it, but still it works. And at this point, they're administered intravenously every month and every other week for lecanemab. But they're all working on ways, I'm sure, of doing this with auto injectors and other. So it's really quite interesting. And the stops on these things, antibodies are given until patients are too severely impaired for lecanemab, or until amyloid is gone in the brain for donanemab. These two studies are, it'd be nice in life if you could really have a head-to-head contest, but that never really works. So the studies are different. And comparisons between the studies are difficult because, for one thing, and you guys can tell me if I'm getting this wrong, I always get, lecanemab included only, its primary target was amyloid. So individuals with amyloid and cognitive impairment, and donanemab, the newer drug, they wanted to look at amyloid and tau. Because let's try and include people who have amyloid and tau because it'll be a more enriched sample. But that makes it harder to match. And their endpoints were different. CDR versus cognitive tests versus whatever. So it gets a lot harder to sort of do any kind of direct comparison between those meds. But we know that they both seem to be effective. Lecanemab is a little bit different. Lecanemab, looks at two different types of amyloid that they call soluble and insoluble. The interesting thing about this that they presented data looking at the idea that there was a lot of evidence to say, and it was sort of summarized in AIC, that really you should keep administering this drug because these diffuse fibrils, these soluble A beta keeps appearing in the brain rather quickly, and it's the thing that does the most damage. So the recommendation was to keep this drug ongoing. And as a matter of fact, they presented here really exciting data showing 36 months worth of drug. And the study itself was 18 months. And you'll see what happened in 18 months when the people who were controls, who look exactly like, you can't, the other thing, of course, about this research is you can't use a control group and give people a sugar pill if they have cognitive impairment, mild cognitive impairment, or early Alzheimer's, because that's not ethical. But you can take other studies that have used large numbers of people and equate them, and that's what both of these groups do. But you can see that this group that looked like the controls here, once they started on drug at the end of the study, for what they call the extension study, where everybody could get drug, they start declining in a very similar way to the people who have been on drug the whole time. So this data was really interesting, showing this idea that we actually see these effects out to 36 months. Things are still slowed down from where people should be. And the same thing happened with their amyloid. So we know that both of these drugs clear amyloid really quickly. And you know, this picture here, don't look at the blue for a second. This picture here is relatively the same for both drugs, but it's quite dramatic, the difference between controls and those not getting drug and those getting drug in the amount of amyloid that's wiped out of the brain. Well, look what happens at 18 months when these individuals get drug. It also drops. Interestingly enough, don't forget, these people have been off drug longer, so they're more advanced in the disease, but it still has a significant effect. So that's an important piece. And both of these drugs have a problem with what's called ARIA. These are brain-associated changes that are seen with these type of anti-amyloid compounds. It's not clear why or how yet, but they're significant, and they may appear as serious brain changes and less serious brain changes. But what this long-term study also was able to show was that it really happened only in the first 6 months predominantly. So that once you can get somebody through those first 6 months, or choose the right people, or put a pause on the medication, it has an effect. The donanemab is a little bit different. It looks at one type of amyloid, a primary type of amyloid, and it's not quite as general, so it's more specific to have a faster effect. And the data that they were presenting that was very interesting was the fact that race did not really make a difference. Clinical stage did not make a difference. ApoE genotype and tau category did all seem to be equally affected, so that the donanemab was having a clear effect across the range. And another thing they did that was very important was they looked at risk consistency. So both companies are doing this. This is Lilly and the other company is Biogen, but if you look at this risk consistency, what's it driven by? We now know, because these drugs have been out long enough, you can sort of predict who's going to have a side effect. And primary above it all is an ApoE4 genotype. So, you know, ApoE4 doesn't guarantee you have Alzheimer's disease, but it really seems to be very much of a predictor of problems. And those with ApoE4 really had a higher risk of ARIA-E in both groups. And the number of baseline microhemorrhages, or the presence of superficial things at baseline. So if you look carefully at a baseline MRI, then and for two different types of ARIA, ARIA-E and H, you can now talk to patients about, look, you want to go on this drug. Let's think about the fact that you're really gaining 5, 18 months, whatever changes. You are running risks, but for you, we can now start to give you a risk estimate of how risky it would be for you to get on this drug. This is really important. And we know that a lot of these other things now, based on this research from the donanemab group, demographics, body weight, weren't consistent, and it really they don't seem to affect it. So it really seems to be, if you do good MRIs and you look at ApoE, you can pretty well tell what's going on. They also presented data, because remember, donanemab said their study was, when you have no amyloid, we're going to take away this drug. And then we're going to monitor you generally and see if it comes back. And they presented data that said, well, out for a long time, that stays the same. So we think we're right in stopping drugs. As a matter of fact, quite a few people were stopped on drug at 24 weeks, let alone later, because they had already cleared all the amyloid. Both of these drugs are fast clearers, especially donanemab. And the widening, they said, look, once you stop drug, it still continues. This decline, this slow decline and a widening decline in that change continues even when you're off drug. So both of these drugs are so new, there's so much looking going on, but they're both quite effective measures and at least in prolonging problems and slowing the progression. The other thing that the donanemab group presented last year and then also at this meeting was the idea of, can you tell people a little more clearly about what it means to go on drug? So can you say in a 76-week trial, there was a slowing of decline of about 5.2 months of savings, which we may say, well, 5.2 months doesn't seem like so much to keep me at the level I was when I went in. But don't forget, if you may see a child married, you may do all sorts of things within that time frame. Plus, it slows the progression overall too. So that's important. So donanemab has got a lot of plans going on. ALZ, the Trailblazer 3 study, they did Trailblazer 1 and 2, and Trailblazer 3 is really going to be an interesting study because the target population is cognitively unimpaired with evidence of amyloid based on blood-based biomarkers. Interesting study, to say the least. And these people have already been recruited, and I think the study has started. I mean, they've been recruited. So it'll be an interesting study. They're also studying donanemab with Down syndrome. Remember, I mentioned that before, so there'll be a study in Down syndrome ongoing as well. So it's really, both of these studies are really interesting. But just because these things are there are still a ton of other studies going on in all different phases. Now, phase 1 is that phase 1 clinical trial is an early phase where you're just kind of, one of the earliest phases are you're basically giving it to a group of, because I used to do this with college students at University of Texas in a facility where if they wanted to do their dissertation, they might come in and you give them a little drug and see what happens. Sorry, that's extreme, but it's not that different from what actually does happen. But then it's tried, phase 1s and phase 2s are tried in patient groups. You begin to look at safety, you begin to look at efficacy, and then there's fewer of these trials ongoing because these are phase 3s. These are large-scale studies to prove effectiveness of the drug for FDA, make them happy. But there are so many different drugs going on in so many different things. I had a pictogram of that, but I've never been able to get that pictogram visible on the screen because there's 3 bazillion drugs and 3 bazillion things. But all these different things, oxidative stress, vascular stress, neuroinflammation is a big hot topic. Amyloid, we've already talked about, tau we've talked about, but improving cell communication, we're doing that now with some of those other drugs, affecting misfolded proteins, neurotransmitters, all sorts of different things going on, all sorts of different drugs and studies. So I'll just mention a couple of them. Remember GLP-1, that probably is going to be a hot topic. It's already a hot topic because it's basically the makeup of Ozempic and Zepbound for drug and for weight and diabetes, or I should say diabetes and weight. Shouldn't say weight first, but unless I'm in Los Angeles. But these drugs have some interesting potential effects in Alzheimer's. And so there was a phase 2 study. Remember, these are small studies just looking for effects done, and they had an endpoint which was brain glucose metabolism. So PET scans, not PET scans for amyloid or tau, but PET scans can also just tell you about how the brain is using energy. I just didn't have time to show you all those pictures, but PET scans, they're the oldest type of scans. PET scans, they tell you how the brain is using energy. And the aim in the study was, I bet if we use this, we can show an increase in energy because we think they thought it would change energy metabolism. No change at all. But interestingly enough, it reduced cognitive decline as much as 18% for the year after the trial. So this was not a primary endpoint, so it can't count. But the point it probably is that these are not drugs that deal with metabolism, but drugs that deal with inflammation. So there's a lot more research going to go on with these compounds, and you're going to see a lot more about them. These results, like I say, they're not definitive, but they're really promising. And there's another one at CTAD, the other Alzheimer's meeting that will come out on therapeutics. And that one will come out with new results. But there's a lot of other intriguing ones, and I put this one in here because I think it's really interesting, right? So one of the problems with all of these great anti-amyloid, anti-tau compounds, these antibodies and things, and these antigens is they don't cross the blood-brain barrier, right? We've got this great blood-brain barrier up here that keeps junk out of getting it up there, unless you hit your head hard enough that it opens up. But it's a problem because then drugs don't get in. So this is an interesting compound that actually trontinemab, everything ends in, but trontinemab. And it crosses the blood-brain barrier through this process that essentially deposits the antigen on the other side. And in a few people, they were able to show these big differences. And in animals, you can show these big differences in where the antigens are actually across the brain rather than in specific areas, based on how it's transmitted. So this is just an early exciting thing that they have been doing a lot of really interesting research in animal research, looking at how to do this and how to try and get some of these compounds that we're giving people now. Let's see if we can give them and do a much bigger job in affecting the entire brain. But between 2004 to 2024, 20 years, a ton of stuff has changed. We have PET scanning, amyloid and tau. We've got new drugs. We've got these insane blood-based biomarkers going around that hopefully we can put a little bit of a understanding to with the committee looking at this very thing and what would be good practice with these blood-based biomarkers. But all these things are going on, new therapies, and this is tau therapy. I will tell you that this is where the next ton of people are going to go, because everybody recognizes the fact that probably Alzheimer's is not really going to be stopped or slow or really slowed or really improved until you start looking at more than just amyloid, because amyloid is down. You need to look at tau. Unfortunately, there's some really interesting tau compounds out there. The ones that have gone to human trials haven't shown anything yet. I don't think there's been one that's really been successful yet. But these tau drugs that affect the clusters of tubules that go up into cells and affect the cells, all this stuff, and trying to break the appearance of tau, all of this stuff is really going to be where we're going, as well as things like just vascular drugs to slow vascular problems in the brain. As a matter of fact, that's what a number of people think will really be the sort of 3 key drugs you'll use in the future to really affect Alzheimer's disease. So I've babbled on, and I still have 45 minutes. Can I do that, or do you want to take a break? Or
we have lunch.
Ah.
So how about going for like another?
Oh, I can do that. As you know, I can do, I could go Babylon for hours, but I will try to do it quickly. So all these cool drugs we have, and everybody is now really paying attention to the fact that what you need to do is precision and personalized medicine the same way cancer does now. Everybody doesn't get the same cancer drug. It's based on your genetic makeup and a number of factors. And people realize that all these things are going to make a difference. And a lot of interesting studies coming out of the Amsterdam group we have studies going on in superagers, people over 80. In Amsterdam, they're studying people over 100. And finding this lady here, they were very proud of. She, at 113, she got the top score of anybody on the cognitive testing measures. But the interesting thing is these genetic profiles look different between the centenarians and other individuals. So again, genetics probably plays a role in all this. We just don't understand. So a lot more to do. So that's one of the reasons why there's this big giant Part the Cloud, Alzheimer's Association, and NIH grant partnership starting to look at early genetic targeting and different ways like CRISPR, where we can sort of change genes. Last year, there was a lot of interest in gene splicing, gene changing, got a little quieter this year, but there's a lot of stuff in there. But the other point about all this stuff and treatment is monoclonal antibodies, we know, only slow disease progression. Most people get diagnosed too late for these drugs because these drugs are supposed to be used in mild cognitive impairment and early Alzheimer's, not in moderate and severe Alzheimer's. People don't get diagnosed soon enough, especially in underserved, underrepresented populations. So, and a ton of people don't qualify for these therapies because they've got something else going on, or they're too tall, or whatever it is. But not too tall. But there are multiple reasons why you don't, or if you have MRI changes, you wouldn't. So what does that mean with all this stuff? It means you're creating this whole population of people that says, oh, I'm sorry, we can't do anything for you. And that's a big problem because the whole issue with the what's the issue with primary care docs? Don't take my time. Don't give me more stuff to do. Now the government says, okay, but if you do spend some time on cognition, we're going to pay you a little bit of money. That's kind of interesting. And more clinicians, primary care docs are actually seeing this and understanding this now, but it takes a long time just to get that message out there. But early diagnosis is not really yet happening, and it won't happen until you give physicians a reason for doing it. Because if you're saying, oh, it's so hard to get on these drugs, or these drugs don't really work that well, and I don't live near a center that's doing the drug or doing by the way, these drugs, because they can have significant side effects. First of all, you've got to do something that shows amyloid in the brain, so a PET scan or CSF. Then you've got to do repeated MRI scans. You've got to be somewhere where all these things are getting done, and that becomes a problem. So what do we do for people who aren't out there? We don't do much. This is what we do. The patient and the care partner are over here, and somehow they have to get over here to dementia care, and it's like going through one of my son's mazes, my grandson's mazes. It's practically impossible. So now, frankly, really, I think in the last 2 years, although everybody says, no, we've been doing it longer, but really in the last 2 years, there's been tremendous movement because people have begun to ask people, frankly, which nobody ever asked before, what stressors do you face in trying to work with your partner who has dementia? Biggest thing was obviously costs and expenses, all those doctor's appointments, all those taxi cabs you have to take, all those other things you have to do. And number two is coordinating with all these doctors and then trying to figure out, I got a portal, but I'll tell you, my portal is like useless at times. And then my portal is telling me things that aren't even there. So all of these things are extremely difficult as individuals get older, and extremely hard if they're trying to help take care of somebody with dementia, just transportation, all of these things. And that has led to this interest in care service providers, and people, rather than saying, okay, now we're going to have a care service provider, rather than doing that, starting from, if we had somebody to help you, what would you want? A big one was a 24/7 helpline, like the Alzheimer's Association has, but one that's local. Coordinating care and communication between different specialists, helping understand all of these things are things that can be done, and people are now beginning to look at that. These care ecosystem models, often led by a nurse with a team of individuals, with a team of care partners who don't have to be licensed, can be bachelor's level individuals, but understand what's available in the community, understand when they need to go up the chain and ask questions, but also can be there to help somebody get through that insane system. You know, we're seeing it nationwide now, all different examples of it and different ways to do it, but it's really very, very exciting. This whole idea of personalized care, again, like you do for cancer, we're going to do for Alzheimer's. And it made CMS, our dear Medicaid owners, think about this. And so they're now pursuing a guide model, which will be tested for 8 years, of course. It takes a long time to test anything in the government, but it's beginning to be, I can't remember how many counties, does this say how many counties have it? I can't remember. It's like, I mean, how many states have it? It's not going to be, it's going to be 8 years in about 6 states or so. But the whole idea is care coordination and management, caregiver support and education, and most important, they will pay not a big amount, but they will pay for respite services. So for somebody else to come in, or a facility that will hold somebody for a day so you can do some other things. There, at least this will be capped at $2,500, but still, this is the first time anybody's ever talked about, except for Debbie Dingell, who tried to get something through Congress, and you know they decided that's not going to work to pay caregivers. But still, this will be a really absolutely phenomenal thing. So 8 years, 96 established, started this month, 294, so it's more than I thought, but they're centers, they're not in states. So it's different centers across the country and ones that have big populations. So I think it's really cool. Medicare Advantage people can't do it, but I think it'll be pretty clear that Medicare Advantage must do it once they begin to see the results come in. But they're hoping to have 200,000 patients in this example, with the whole idea of if you go in and see your primary care doctor who diagnoses you early, thinks about maybe I can confirm things and put you in a clinical trial, or I will give you a managed care primary care. The Alzheimer's Association does something similar to this in a sense at Henry Ford, where they have social workers, Alzheimer's Association social workers are in the neurology clinic to help patients. So it's a pretty neat system. And it provides for the, we forget the importance of, it provides for the primary care physician, once I diagnose, I want to know what to do. And I'm not going to diagnose if I don't know what to do. So this is a really important thing that's really only cropped up recently. So risk reduction research in 5 to 7 minutes, I can do it. So the first thing that happened here was Lancet. Every 3 years, the Lancet journal, they have a Lancet commission, comes out with a study on risk modification. And this is a pretty cool thing because they select different risk factors based on the literature. And then these are probably too small for you to see, but they select these different risk factors and then make suggestions on what you can do about it. But you can see early life, less education is clearly an issue. And in parts about a 5% risk. We were just talking about education. Midlife. Now we have hearing loss and high LDL cholesterol. Cholesterol bounced into the list this time. It hadn't been there before, but there's enough research now to show that it's important, and it matches hearing loss with its highest risk things. And this is irrespective of ApoE and other genetic features. Depression, smoking, hypertension, all these other ones have smaller things. And then in late life, you have social isolation, air pollution, and visual loss. It's not necessarily that visual loss is only in late life. It's just that there haven't been enough studies. But these things are important because these things are trying to say, okay, let's reduce your risk of having this disease. I may not be able to affect your genes, probably, but I can affect some of the other things that we know contribute and have a contributory factor to Alzheimer's disease. The big one here got a lot of press was air pollution, right? 10-year study, more than 1.2 million Californians aged 60 years and older. And there was a significantly stronger effect of wildfire smoke in this area than there was of other air pollutants like motor vehicle, cars, and factories, right? We all think of California, of all these cars spitting out all this stuff, but the small scale pollutants from fire were much more, and from whether it was the heat and it's not clear what the reason is, but it's something that clearly deserves particular attention. But, and if you look in California and other places, air pollution produced by wildfires accounts for 70% of the fine particulate matter. Now, I spent all last summer outside with my puppy dogs because I was trying to housebreak them. And so I was out there during the whole Canadian thing, so who knows what I've done to myself. But you can see, first of all, large infarcts are related to air pollution, and we've known that for a long time. But this new large study was able to show the importance of in Alzheimer's disease and air pollutants. There was also a lot more things about diet and lifestyle, and as an Italian, this one kind of hurt the most. But a very large study, 17,548 participants, eating about 2 servings per week of processed red meat raised the risk of dementia by 14% compared to those who eat greater than 1 serving. So, I mean, it was processed red meats include salami, pepperoni, hot dog sauce, all of my main food staples. You took away Popeye's fried chicken from me, and this is the next one to go. But it's really important. Swapping out a serving of nuts or beans or tofu made a difference. So this is really a big deal going on. And this study that showed the effect, and this other study, even bigger study that showed you get about 1.6 years of cognitive aging for global cognition and 1.7 years of cognitive aging for memory if you're eating processed meats. So, I'll be good, but it's hard. And then there were also a number of studies about the US pointer study. There are worldwide pointer studies going on coordinated by the Alzheimer's, that all worldwide finger studies going on, but we don't use the word finger here. We use pointer because it's a little more appropriate, I guess. But our study this study will be out probably in, I think it's 2025, late 2025. They'll begin to produce, because it got delayed by COVID, whereas other countries had already started theirs. Other countries like Amsterdam, England, and several of the other European groups and the Chinese finger studies, they're all on finger 2 and finger 3, where they're beginning to look at lifestyle changes with eating and things like that. But we're coming along too. Of course, the US one emphasizes you do what you're told, or you get to decide what you want to do. Very kind of political in some ways, but that's the difference on the US. Because every one of these finger studies across the world are established not only to look at the effects of healthy eating, cognitive training, physical activity, and all these things, but they're also established that in every country, every region, they are adapted to the population. So adapting to us meant either free to do whatever you want and do it or not do it, or read the book or don't read the book, versus somebody who sort of meets with you every day to make sure you've read the book. But it'll be interesting to see those results. So save the date next year. It'll be in Toronto, Canada. This is a great place to watch a baseball game. Even better if you can pay a fortune and get one of the hotel windows that overlook the baseball field to watch the fireworks every night and stuff like that. And there's a nice Italian district here, but now I can't go there anymore. I don't have any, So this is the Michigan Alzheimer's Center. We cross Michigan State, Michigan, Wayne State, of course, Michigan State, gonna have two. Sorry, I didn't mean to be picky on Michigan State, but this is we have a very large center. We're one of 37 in the United States. Centers of Excellence for Alzheimer's Research. We have a long-term study that follows people over time, once a year for evaluations. We have all sorts of affiliated studies. We have, I thought actually, this will be just a few seconds. Stephanie's left. Oh, she hasn't left. Okay, right. Okay, I'm almost done. But I was going to say, I thought you made the clicker stop working. Is the way to stop working. It's usually better because usually Stephanie's in the back of the room going, enough. But we have, this guy's in the audience. This is a study, a very interesting study looking at EEG as a very early marker of cognitive loss. And we have a driving study that I'm kind of particularly interested in because the government gave me the money, where we're looking at driving simulators, people's cars over fixed courses and other things, as we look to see what happens with aging and driving and how those things may signal changes for us in general. Vascular studies going on, the super aging study I mentioned, people over 80. We also do more than research. There's Edna, and Edna does the teaching or tells me what to teach, and I listen to Edna. We also do programs in the Matai Botanical Garden for care partners, caregivers. We have a wellness initiative. That's Laura Rice. I always have Laura's picture there because sometimes Edna scares me. Laura makes me relax. So it works out fine. We have a Lewy body initiative. We're one of the largest in the country looking at Lewy body and helping with Lewy body support groups. We have our brain bank that helps us learn things after somebody passes away. Most important of all is, what was the real diagnosis? These guys that guy back there, they're really irritating because in the end, you can't beat the pathologist. They're always right because you're dead and they got your brain. So they take great pleasure in having us monthly present in this thing that Stephanie arranges, this clinical pathological conference, where you get the neurologist and the neuropsychologist, and they go, oh, we think it's this, and we think that it's very clearly this and that. And then the stupid pathologists come along and go, no, you guys are completely wrong. But every time we're right or wrong, we learn something very important. So I can't complain. And this is everybody, and this is our addresses and our phone number if you have questions. But you can also just bother Stephanie if you want something. So that's the end of that. Thank you. See? I did it.
I have one quick question.
Sure.
When you make your presentation.
More questions, slower than lunch, unless they can. But yeah, no, I'll be here to answer questions during lunch. Yes, it gets, Stephanie puts it up on the website or whatever she does. What did she do?
Yeah, put it up on YouTube. And if you want to send me these slides, or I can pull the slides up.
Yeah. Okay. Any other questions? I'm sorry, it's so much stuff goes so fast, but there's just so much stuff going on, you know. Last year there wasn't all this excitement over blood-based biomarkers, so it wasn't moving along, but. No other questions? Oh, yeah. Uh-oh. No, okay. Oh, here comes one I'm not gonna like. Huh?
Should I start with them?
I'm not getting into that conversation.
The point here is that I believe that.
Yeah.
Key features.
Yep.
And if you not answer, measurements. I personally believe because all mountains like this for
But I can't guarantee you that those are actually inflammatory meds. That it'll affect inflammation. I think that's what it does in my brief read. There's a few other people who feel that it's more of a inflammation than a metabolism. Don't put this or I'll get yelled at by all sorts of people, but no, it's just not clear. So yes. Oh, wait, 1 second. But don't necessarily do it unless it look for amyloid first. You gotta consider these things. People run out. We had, when the drugs were first becoming available, the PET scans were not covered by CMS yet. And we had people willing to put out of pocket desperately to get the PET scans and the MRI scans out of pocket. And because there didn't seem to be a clinical reason for doing it and whatever, now the companies are helping with that, which is important too. But yes, I'm sorry.
With the newer drugs, like, so why would those people be more predisposed to have side effects?
I mean, we may have to ask the people who know more about that than I, but I think at this point in life, it's a finding, you know, that needs a lot of work as to why, but we know what those drugs affect. And we also know that it's, if you carry the 4 alleles versus 2, whatever, it has a lessening effect. It's really interesting. And it really should help in conversations with patients that make an informed choice. Yes.
Were there any of those poster boards that the AI has on mirror neurons?
I, don't know because I didn't get all the posters. I didn't hit every one of the posters, but I can look it up for you afterwards if you want. Just don't let me go and I'll look it up and see if it's, because I've still got it on my phone.
Caregiver doesn't know are being transferred into him where they neglect themselves and
Yeah.
build up
What?
the nervousness of
You don't go to the doctor. You don't go to the doctor as much. You're depressed. You're anxious. You're constantly being traumatized by trying to get through that medical system. It all has a significant effect. That guy over there studies mirror effects in EEG, which is interesting too. You. So you can also talk to him too, but I can look it up for you. I can see.
I just say.
Yeah.
Alzheimer's disease is contract this outside. Wherever we look, there is something wrong. The Alzheimer's brain doesn't tell. But we have a few points today. There is this so-called hyperscanning. Scan 2 brains at the same time, and you can evaluate sort of degree of closeness or attachment to each other. Now, are there only mirror neurons, or there are some other systems in the brain which start to synchronize? That's
And developmentally, people are interested in that between a child and a parent. Anything? Yes. Sorry for sitting down, but my back said sit. Well, there's, there've been a sequence of ones that people looked at that haven't really proven to be effective. We've got, some vitamin-based and other derivative-based compounds out there that people are selling on TV like crazy that really are failed compounds that didn't pass clinical trials. But because they were nutraceuticals in this country, you can sell them. So if they're vitamin compounds and other things, but so far it's not clear. People have been interested in vitamin D, vitamin E, vitamin D especially is a big issue. I mean, in Africa, we spend a lot of time looking at vitamin D because you may say people are out in the sun, but there are different forms of vitamin D. And when we look at the different forms of vitamin D, if you don't supplement, you find really significant problems among HIV patients as well as elderly. And we're wondering if that's really one of the things that contributes to Alzheimer's disease. So it's an interesting question that nobody really knows the answer to. Yes.
You had on there, Miami-Dade County has 16.6% of their population has Alzheimer's.
Yep.
Out of 100.
I won't say that has anything to do with voting rules. No, but I mean, you see, but don't forget, these are population areas where there are a lot of older people live. Now that's changing as you get all these younger people coming to Florida, but you see California also is high. So, and the southern states are high that may be related to diet and other things as well. But a lot of these counties, one of the counties is in Jersey, I think, if I remember. So it's unclear why you get pockets like that. And these pockets often are randomized. But we do know that certain states, based on how people live, have a much higher prevalence. But say Parkinson's disease in people felt very strongly that it was related to fertilizer use and other use in Canada. And it turned out that was a misunderstanding of the data. Yeah, I don't know. I mean, actually, I don't know that for sure, because a lot of that stuff got debunked when, there's a lot of stuff in science that comes up because of, remember aluminum in aluminum pans? My mother spent a fortune on aluminum pans that all went into the trash when she heard about aluminum and Alzheimer's disease. And it has, I'd say it has nothing to do with Alzheimer's disease, but now there's some people actually returning back to the same studies to say, oh, maybe it does. So, it's not clear whether it's a byproduct of the disease or does it actually contribute to the disease. It's unclear. Yes. All those guys out there with ApoE3 and ApoE2, they're that, if we understood who were the people with good genes, we'd be all set. But nobody has really been studied. Everybody's been fixated. Let's first figure out how to diagnose this disease, how to treat this disease. And only, Europeans are much faster than we are at this. But in this country, we don't tend to do big scale studies in some ways that don't look at only one thing. And so now there's a lot more interest in genetic markers for what are successful genes. And genes in African Americans appear to be different than white population. All these things are getting very specific, but that's the issue of trying to do personalized medicine. they are beginning to do that with a couple of new Alzheimer's drugs as well, saying that we think that if we link this to this gene, it may have more of an effect. So, and there are even some, you know, they ran afoul of the government a while back, but there's some people trying to change genes. You know, so it's a lot of interesting stuff. Okay? Okay, sorry to keep you from lunch, but I gave it. You're welcome.
Pleasure to have you.
The only slide in the whole thing that would be a problem is, oh,
I get first by Rodney.
oh, hi.
I'm
I'm sorry.
Oh, no, you're fine.
Yeah, I know,
You're
I know
totally
you're-
fine. Yeah, so we're just here to support you. I kind of cover everything.